Good morning and welcome. I am Dr. Joanne Yanes, the Executive Director for the Association of Accredited Naturopathic Medical Colleges, and I welcome you to today's webinar, Eating Disorders, Naturopathic Care Can Help, with Dr. Lily Stokely. Dr. Stokely joins us from the great state of Washington, and she is going to be talking to us a little bit about eating disorders today, her experience with that, as well as some tips for you all. Before we get started, I just want to go through a little bit of housekeeping. So if you have questions today, there is a Q&A tab on your Zoom platform. Please enter your questions in there and not the chat. We'll keep the chat for other things, but if you have questions about the webinar, please use the Q&A box so we can manage those questions a little bit more easily. And the webinar is being recorded and will be sent out as well as available on our website and our social media platforms and so on a little bit later on. So with that, I give you Dr. Lily Stokely. Thank you so much for joining us. I'm going to make my face go away, but I will be here listening and paying attention to the questions. Thanks for joining us.
Thanks, Joanne, and it's a pleasure to be here today. Yeah, I'm excited to share about this topic. It's kind of a passion of mine and something that I think there's a lot more education needed to be presented around. So I'm excited to get to share a little bit of how I practice and hopefully inspire a few people to consider this as something to specialize in. So I started my education at the University of California, Berkeley. I studied dietetics at that point. I thought that I was going in to kind of be a registered dietitian. I was really excited about the program and feel like I gained a lot of information. I had quite a bit of exposure in that field around eating disorders at that point. And kind of continued to feel this sense that there was more to it. We were learning a lot about nutrition, and I felt like that's a great aspect of health, and that there was just more about health that I wanted to know from that. I have a lot of respect for dietitians. I think it's an incredible field, but personally just felt like there was a lot more information that I wanted to understand about the body. At that point, I really didn't know what naturopathic medicine was, but I knew that there was something more that I needed to learn. I also got involved at that point with an organization called the Body Positive. It's based out of the Bay Area. They're a nonprofit organization that's really targeting eating disorder prevention through work around body image, starting from actually elementary school age all the way through college and now professional trainings. I started doing trainings with them and got even more exposure kind of into the eating disorder field and just kind of how prominent it was that we needed more providers and more training to be able to really provide accessible and informative care for people that are struggling, and really most importantly, preventing eating disorders. At that point, I took a little bit of time off. I took a couple gap years. I started teaching yoga, did a little bit of traveling, and still was kind of trying to decide what I wanted to learn, but still through yoga and now nutrition also still had this feeling of like there's more to health that I still didn't fully understand. At that point, I started doing just reading around health and started hearing the word of naturopathic medicine and started looking into that more. And I remember the first time I read Bastier's website, it was the first time that I'd really just heard in kind of a concise way, a description of a healthcare provider that really covered all foundations of health and not just individually looking at one at a time. So I got really excited. I applied from a beach in Thailand and quickly returned to the United States to start school at Bastyr. After Bastyr, I did a 2-year CNME approved residency in a primary care residency site in Seattle at Emerald City Clinic. And started building connections with a lot of eating disorder treatment centers and eating disorder providers in the Seattle area and the United States at large there. So I'll tell you a little bit more about kind of some of the extra training that I did to specialize in this field. So I did just an undergrad training with the Body Positive, where I was doing peer-to-peer training and counseling, teaching classes around body positivity, working with sororities in eating disorder prevention, working with high school age and elementary age and with eating that. And through that just had a lot of contact with kind of foundationally how culture and our school systems and our medical system in some ways is contributing to eating disorder formation. So I felt really inspired that this was an area that I wanted to dedicate more time. In the Seattle area, we're really lucky. We have a lot of excellent eating disorder we have a lot of excellent eating disorder treatment centers. So Opal Food and Body Wisdom, Center for Discovery, Eating Recovery Center, and the Emily program are all here locally. If you're interested in eating disorder treatment, it's always really helpful to connect with your local eating disorder treatment facilities. They provide CE trainings. They have a lot of kind of networking support groups. They have a lot of free education that you can participate in. And so I've gained a lot of knowledge just working one-on-one with different eating disorder providers as well as the treatment centers. There's a few people based out of Denver that I've done some learning with, Philip Mailer and then also Jennifer Wadiani. Both of them have books that are incredible around eating disorder care and are two people that are pretty prominent in eating disorder treatment. So learning from them and a lot of the writing that they've done is another kind of foundation to specializing in this. And then preceptorships. Learning from other doctors and physicians. There's definitely a need for more experienced providers in eating disorder care. So a lot of my preceptorships actually were with dietitians and therapists learning around this kind of eating disorder specialty and then applying that in naturopathic medicine with a few specific approaches. So I feel really lucky to have combined a lot of these different modalities and working with a lot of different people in our community. I'm also hoping to really develop this specialty within naturopathic medicine. So there are kind of continued ways to continue that education there. So agenda for today, I just want to kind of hope that you can take away just the clear role of what a naturopathic physician can provide in an integrative outpatient approach to eating disorder treatment. There's a lot of naturopathic physicians that are also doing an inpatient approach as well. There's some incredible opportunities in a few inpatient treatment centers, but speaking from my perspective, this will be really outpatient treatment only. And then learning a little bit about diagnosis and naturopathic treatment of eating disorders. So if someone is diagnosed or you're making that diagnosis, how do you then move into an appropriate treatment and what a naturopathic treatment may look like there? And then really where I'm most passionate is eating disorder prevention. And I think whether you're specializing in eating disorder care or not, that prevention is really foundational. So you don't need to know necessarily how to treat an eating disorder, but you do need to have that base level skill of what can maybe put someone at risk for an eating disorder or what language we might be using that contributes to that, to a disordered body image or a disordered relationship with food or exercise. And then I want to just share one patient story. I've got many to share, but a patient story around overcoming disordered eating and how that looks kind of emotionally and kind of mental emotional health, but also in physical health and laboratory markers. So hopefully you'll gain a lot of information moving forward. So the role of an ND is many things. I've kind of covered a few of these, but really to prevent, that's kind of foundation in our philosophy as well. We want to prevent illness before it occurs. And I think this is an area where a lot of this is really learning the appropriate language to be using around our recommendations with diet and exercise. Also just identifying in our own bodies, our own potential opportunities for identifying bias. So bias around diet, bias around weight, those components that we really need to, as physicians or medical providers to have a good understanding of before we can start working with patients. So I think that's foundational as a naturopathic physician, is that we need to continue to do our own work in this. We can diagnose in most states, so it depends on where you are practicing. In Washington state, we're lucky we can make diagnosis. There's a significant amount of lab management in eating disorders. Mostly we're wanting to make sure that someone is remaining stable, being able to provide information when their body maybe is becoming less stable. And part of this on the next slide, you'll see that that's also helping me determine what level of care that individual might be needing. So do we need to step up to a higher level of care? And I'll explain some of those options in just a moment as well. And then
Dr. Stokely, before you move on, I just want to let you know we're putting up the poll today to just understand who is in the audience. So if you're listening to the webinar, please take the poll. We'll be closing it in about a minute. Thanks.
Thank you.
Yeah, you bet.
So treatment of eating disorders, I think one of the amazing things about naturopathic medicine is that there are so many different treatment modalities and tools. And the thing that really ties our treatment modalities together is the philosophy, but there's still a lot of different ways that treatment can be applied. So this is an example of how I use treatment. There may be a lot of other approaches out there as well. But a predominant part of the treatment I use for eating disorders is really counseling, really establishing rapport with an individual, building trust with that individual so that we have a connection, so that if I make recommendations that might be challenging for someone to step out and be brave, courageous, to try something different in regards to working with their eating disorder, that we have that foundational relationship already established. From there, there's a lot of also care coordination that's happening as a naturopathic physician. So I always say that even though an ND has all the skill sets, we can do counseling, we can do lab management, we can diagnose, we have a solid nutrition background as well. Even though we have all of those tools in eating disorder care, it's really important that you're working in a team approach. And part of that is that you really need a community around that individual that is struggling to be able to hear in maybe many different ways how it's important that they start to change the nourishment of their body or relationship with their body. So I'll often work alongside a psychiatrist, a therapist, a dietitian, sometimes also an acupuncturist, sometimes also a physical therapist or some kind of a movement specialist. So there's a lot of different kind of people that are supporting this individual potentially. Sometimes also someone's stepping down from a treatment center and there might be care coordination around stepping down or stepping up. So there's a lot of kind of a side work going into phone calls and management, not even necessarily one-on-one with the patient. It's something I really love about eating disorder care because I feel really involved in the community of medical providers around me. It's also a really incredible way to stay up to date, to continue to be educated, to be pushed by other providers to continue learning. There is sometimes a significant amount of medication management. A lot of people are sometimes stepping down from treatment centers where psychiatric medications have already been prescribed. Sometimes there's a need to prescribe medication, mostly as I think of it as kind of a stepping stone of needing to support someone when there can be really intense anxiety, intense depression that's often coinciding with that eating disorder. And then a lot of herb and supplement management. And this piece of it also is, and I'll get to in the following slide, is just an area of also in the recovery of an eating disorder when someone's starting to heal in different ways. There are a lot of other sequelae that can start to pop up. And there's not a lot of other tools in conventional medicine to necessarily support those sequelae. And so this is, I think, really an area where naturopathic medicine shines, where I can support someone in those digestive sequelae that might be lingering from a slowed digestive system. From prior malnourishment. There may be other areas where I can really support anxiety and depression without the use of increasing medication doses. So this is really where I think the care in an ND model really thrives in eating disorder treatment. All right, so just a brief overview of diagnosis of eating disorders. This is something that's really easy to look up online, so I won't spend a lot of time here. But there's several categories of eating disorders. There's anorexia nervosa, which is really restriction, severe restriction, where the body is typically at an underweight or lower weight. I just really want to reiterate in this that you cannot determine an eating disorder based on someone's body size. That eating disorders are traditionally thought to be a visible illness, and it is very much a false expectation of eating disorder care. So I really want to make that component clear. And I'm going to jump down to the bottom of the slide, just the other specified eating disorder, where you're going to see atypical anorexia. This is actually a category of eating disorders that I treat most predominantly. And atypical anorexia means that the individual is severely restricting a caloric intake to a point where it's putting their body at danger, but their body weight is not considered at a low body weight according to BMI standards. There are a lot of individuals in that category that actually have been misdiagnosed in the past because of that body weight component. So going back up to the top, there's also bulimia, which is using compensatory behaviors, so purging, laxative use. There's binge eating disorder, which is I would describe as eating beyond comfort to significant levels multiple times a day or a week. And then avoidant restrictive food intake disorder is an interesting one, and it's kind of an emerging eating disorder that there I think is a need for further understanding around. There's a pretty significant overlap with autism as well, with avoidant restrictive food intake disorder. Also other conditions like PANS and PANDAS can overlap with avoidant restrictive food intake disorder. Basically, it can be described as very picky eating that actually puts the body at risk because of restriction from a fear of certain foods or food groups. And then another one just under the other specified eating disorder category is orthorexia. So basically described as spending a lot of time thinking about food and quality of food and restricting food because of a need or a want, a desire to be healthy, that's actually then impacting health because of those restrictions. So that's actually another really prevalent one that is just starting to be talked about in the health world, and I think also very relevant in our communities where we are more health focused in that way. All right. So treatment of eating disorders, I mentioned already, just part of the work is identifying the appropriate level of care. So where do they need to be supported in terms of a safety concern? So there are concerns with renourishing someone, or historically called refeeding someone, where sometimes their bodies can do different metabolic things where it actually puts them at risk as they're adding more food in, or as they're changing some of those behaviors. So if they're at risk for some of those things, that's usually a warning sign that they need to be at a higher level of care, that outpatient management isn't necessarily a safe place to be. A lot of my job is also prepping someone to step up to higher level of care. At any phase in life, whether an adolescent or an adult, stepping up to higher level of care is a really huge commitment, and it's really scary for a lot of people. And I think traditionally, because there aren't a lot of options for outpatient care, that people are pushed into higher level of care sometimes before they're ready, or sometimes even against their will. And so a lot of my outpatient support is actually taking some steps, some small steps of getting someone slightly renourished before they step up to that higher level of care, so that when they step up to higher level of care, the sequelae of renourishing is actually a lot more tolerated. They also know that they have support as they're stepping down. So someone may go up to higher level of care, and then when they're done with that, it used to be thought, oh, you're recovered, your body's renourished, and now your eating disorder is gone. But a lot of the time someone's left at that phase still feeling like there are really loud eating disorder thoughts, urges to restrict, or urges to have behaviors that were there before, even if they're maybe not acting on them. And so having a care team that someone is already familiar with, that they get to then go back to when they're stepping down into outpatient, also really improves the success of someone's continued recovery and maintenance of recovery in that regard. So I love to be able to get to see people step up and support them in that, and have that be a decision that they're really on board with and feel supported with by their outpatient team. And then also be there to kind of catch them when they step down from those higher levels of care, to continue that work in that outpatient setting. So there's several levels of care. There's going to be intensive outpatient, which is the level of care we're talking about mostly today. Intensive outpatient, which is usually where there's about 3 hours a day, 5 days a week, someone's going into a treatment center, working with a dietitian and a therapist predominantly through a treatment center. There's partial hospitalization, which is basically they go there usually 5 to 6 days a week. You're there all day, eating all 3 meals there during the days that you're there, working extensively with therapists and dietitians, sometimes medical providers, physicians as well. And then there's usually also a lot of group work that's being done at that setting, but you go home at night, you go sleep in your own bed. And then there's residential, where you're there 24 hours a day. Depending on the residential program, this can sometimes start to feel a little bit more like a hospital, but not always. There are programs that are residential that are really trying to set up their system to have it feel a little bit more like a home. And then there's the higher level, which is going to be inpatient. And that's really where our highest risk individuals are, where there are really significant risks for refeeding syndrome, or kind of more serious things as someone is renourishing, or sometimes just really complicated other confounding medical components that put someone at higher risk. So as we talked about already, the most important part of treating eating disorders is really supporting someone in developing a treatment team. So being able to know who to refer to for this. And I think really reassuring yourself that you are not supposed to do this all by yourself. So I have a long list of dietitians that I refer to, a long list of therapists that I refer to, and my job as someone is coming to establish care with me is to try to match them up with the person that I think they might do the best with. So I'm thinking about personality traits, other interests that might make them connect with someone in a different way. And usually when I'm referring someone to a dietitian and a therapist, I'm asking them to usually go about once a week with each one. So it's a big commitment. And I want there to also be that connection, that rapport with the people I'm referring to. And then we spend a lot of time in our first few visits uncovering what I call the body story. Basically, what are all the things, what are all the messages, all the maybe traumas or the experiences in that individual's body that have maybe led to the disordered eating or eating disorder in that moment. And the way I describe an eating disorder is that it's a coping mechanism that it has developed trying to protect something. It's trying to protect that individual from something. And it may be causing certain harm in that body, but there's for some reason that eating disorder or behavior developed that was trying to be protective to the body's best knowledge. And so the way I phrase that is that we want to really do the work to be able to then understand what the underlying need is, so that that individual can start to figure out what else might fill their cup in protecting them without the risk factors associated with the current behaviors. So until we understand what that need is, it's really hard to start making changes because the eating disorder is still protecting that need. And then the next thing we are working on, as I already mentioned, is treating the sequelae of eating disorder symptoms. So digestive components are really a huge part of eating disorders. For really all forms of eating disorders, there's different forms of digestive distress that can occur. In restriction, really the digestive tract is slowing down significantly. Thinking of the digestive tract as a muscle, if you're not getting enough nourishment, that muscle is going to become weak. That can look like constipation, diarrhea, gas, bloating. A lot of digestive symptoms are actually sometimes what lead to someone having disordered eating, and also can mask an eating disorder for instance, people saying, I can't eat this because it's hurting my digestion in this way. And it's tricky because if someone is struggling with digestion, sometimes it's simply that their body's not getting enough nourishment, that their digestive tract is having these symptoms. So it takes a careful eye to be able to identify, maybe this isn't actually a digestive concern, maybe this really is an eating disorder concern. So that kind of goes more into the diagnostics of eating disorders, particularly relevant in naturopathic medicine, because I think a lot of patients come to naturopathic physicians because of digestive concerns. So in some ways, that is where we may get even more exposure of needing to diagnose eating disorders in that realm. So I use a combination of herbs and homeopathics and medications kind of as my primary treatment modalities. I also do a little bit of hands-on work. I use visceral manipulation when someone's really ready, if they're okay having touch to their abdomen. It's a wonderful tool to be able to work with possible restrictions to help get the gut moving in a different way that's not always about just adding herbs or something they're taking orally. And then, as I said already, a thorough lab evaluation. I'll give some examples of labs that can sometimes come up in certain eating disorders. I also like using the labs because it's a way to start connecting someone to their body. Of like, hey, there's this lab marker here. How might this actually be experienced in your body? So it's not just something on a piece of paper. So I spend a lot of time explaining labs, going over every lab value and what that might mean for their body. And in eating disorders, it's really important. There's a couple things that come up with that. One piece is that it's very common in eating disorders for people to say that they aren't sick enough to warrant care. And so with labs, I'm also using that as an example and a way to say, hey, this is maybe how your body is so resilient that you are holding on really strongly, and to build respect for the body in that way. And those labs can change at any time. And why we continue to run those labs is to make sure that the body is not decompensating. Sometimes we also use those labs if there are big changes happening to say, look, your body is stressed here and you are sick enough to warrant care. So there's a lot of discussion around, in most visits with eating disorder patients, around the idea that they do warrant care, that their bodies are sick enough, that they don't need to be sicker to deserve the care that their body is asking for. And then coordination of care. I think I mentioned this already, just that we're kind of I think of naturopathic physicians, if you can play a primary care role or kind of that diagnosis management role, that we can be that central point in that individual's treatment team. So making sure that everyone is talking to each other, making sure that everyone has signed releases so that the therapist can talk to the dietitian, so that I can talk to everyone. Sometimes that includes being able to talk to a family member or a support team at home as well. All right. So just an aside, just that with this eating disorder prevention piece, that this is kind of where I think that my passion in this really starts, is that eating disorders are a social justice issue. I think when I was mentioning someone really sorting through someone's body story, it's important to remember that a lot of people's body stories also start with a culture that is often weight biased, or very diet and exercise or health focused. And so the weight bias that's occurring in our culture is something that in order to really work in eating disorder care, you also have to work in that preventative piece and provide education around where weight bias is occurring. Some examples of this are that there are often, when you walk into a medical facility, not chairs that will fit bodies of all body sizes. Many medical providers don't have blood pressure cuffs or medical equipment that's appropriate for all body sizes. Those are just a couple examples that might show up in a medical office. And so as part of that kind of breaking that system, part of my social justice work is actually to provide seating that's appropriate for all body sizes. I have a scale that goes up to higher body weights. I have blood pressure cuffs that will fit all body sizes. So really making a space that is safe for people of all size. And that's just a starting place. I think there's a lot of other ways that we can also, as providers, provide education and make sure that our system is not causing harm to individuals. And a lot of the work that I do in visits, whether someone has an eating disorder or not, is to really start to debunk where we might be getting messages around our body size, our diet, or shame around food or exercise that maybe are the voice of our culture and not necessarily the voice or the messages our body itself is giving us. So an important piece of eating disorder prevention. And the other aspect to that is really reducing harm with all patients. So I avoid prescribing restrictive diets. I don't do any food shaming. And I think sometimes when we talk about food shaming, people are like, well, I don't do food shaming. But sometimes if we say, oh, I can't believe you ate that, or even if we say it about our own body of, wow, I can't believe I ate that, that in itself is actually applying shame to a certain food or a food group and can affect other people around us. So I'm very careful with the language I use around talking about diet and exercise and people's relationships with their body. And there's two questions that I use to really start to dig in to assess where someone is in their relationship with food and where someone is in their relationship with their body. In medicine, we talk a lot about like, well, you don't prescribe a restrictive diet if someone's at risk for an eating disorder. But we also need that education around, well, how do you know if someone is at risk for an eating disorder? And these are the questions that I like to start with. So I ask, what is your relationship to food? And then also, what is your relationship to your body? And usually with those two questions, I can start to get an idea of where someone is in terms of how they're navigating food decisions and how they're navigating body image amidst a culture that is slightly weight biased. So a case study here, and I chose binge eating disorder partially because I think there is a lot of stigma in terms of kind of weight bias around binge eating disorder. So I think this is an area where we need more education there. So this is a 45-year-old female with binge eating disorder. She has GERD, which is acid reflux, and prediabetes. She has a 30-year history of binge eating with multiple past treatment attempts. So she's coming to me after seeing probably 5 or 6 other providers in the last few years, many of which have prescribed other diets, have tried to assist in weight loss. And what she comes in saying is that her binge eating disorder is getting worse every time she tries to go on a diet. The individual inhabits a larger body, and I think that's a piece of why other providers are maybe recommending that she go on a diet each time. She's got significantly reduced caloric intake during the day, so she skips breakfast often, eats a very small lunch, and then her evening binge behaviors are really where that behavior kicks in. And the way I describe that in binge eating disorder is that anytime someone is eating beyond comfort, so eating an amount of food that feels uncomfortably full in their digestive tract, that it usually about 90% of the time means that at some point earlier in the day or maybe even earlier in the week, there was a deficiency in intake. And so this is kind of the catch-22 of that. If a lot of the time with binge eating disorder, because someone may be presenting in a body of larger size, they're being told to go on a diet, which is usually restricting intake, but that restriction of intake is actually what's contributing to the binge eating behavior. What we also know about this is that when someone is restricting and then binging and having that pattern back and forth, is that actually puts the body at higher risk of changes in blood sugar, of changes in cholesterol and lipids. And so the individual presenting with a blood sugar of a hemoglobin A1C of 5.8, which is in a pre-diabetes range, has been told that it's because of her body size. When we started to do this work together, what she realized is that it may not have been because of her body size, but actually because of that binge restrict cycle, that inconsistent food intake, which is hard and taxing on the blood sugar and insulin levels. So her hemoglobin A1C was mildly elevated. She had elevated triglycerides of 250. The most optimal for that is usually nothing above 150 or usually closer to 100. Her cholesterol was elevated at 245. Her LDL, the cholesterol that's less protective, was elevated at 125. And then her liver enzymes AST and ALT were both mildly elevated as well. And her main symptoms were that she felt fatigued and that she had reflux and bloating. So a lot of digestive symptoms, which is really common in binge eating disorder because the body's getting a larger bolus of food all at once. The digestive tract has a hard time digesting all of that all at once, has a harder time with enzyme production all at once. So something that I can add in, just even for symptom management while we're working on the emotional piece and also the food intake piece, is adding digestive enzymes or herbs that help with the bloating or reflux, adding soothing herbs to help support the esophagus and the stomach, maybe even adding some adrenal support or certain vitamins to help with the energy piece of it. So there's a lot we can even do for the symptom component while the individual is working on the other underlying components to the eating disorder. So we did a lot of counseling around weight bias. This is where that kind of work around the body story and our social and cultural influences of our weight come in. We talked a lot about that binge restrict cycle of that if she is having binge behaviors, we always have to look back at where there's been restriction earlier in the day or the week. And we talked about just that the abnormal lab findings can sometimes happen regardless of the weight, that it is often a sign of that the body is going through that binge restrict cycle or even a weight cycle of losing weight and then regaining weight. And so our focus for her treatment was, can we get consistent food intake in, focusing on getting breakfast in and getting lunch in consistently, and over time seeing if those binge behaviors in the evening might lessen. We reset expectations that the treatment goal is not to lose weight, and that that in order to successfully treat binge eating disorder, this has to be a foundational component and a commitment from the provider and the patient that weight loss is not the goal. Explanation of hunger and fullness cues. So really starting to identify what are the signals that her body gives her of how much to eat and when she might need to eat if we're not using a diet model to guide her in what foods to be eating. And I referred her to a dietitian and a therapist. And the way I phrase that as a naturopathic physician is that I want to make sure that I'm giving her enough support from the medical perspectives, that we do counseling and we do work with her nutrition in every single visit. But I want to make sure that she's getting that weekly support, sometimes even twice weekly support with someone. And a lot of the time my schedule doesn't allow for me to see patients that often. So I want to make sure she's getting those regular check-ins, because as she's starting to do this work, there can be so many questions that start to come up. And so I want her to have a support team that's right there every week to answer those questions and to explore what's going on in her body with her. And then we do usually about once a month check-ins together to be able to then sort through and organize everything that's come up in the last month, see if we need to add different supports in for different symptoms that are arising. In this case, with the elevated liver enzymes and the cholesterol and the blood sugar, I also started her on some herbal support for liver support and blood sugar support that were really specific to those symptoms to help her body stabilize there as well. I mentioned visceral manipulation earlier. That's the abdominal form of abdominal work, really working with abdominal tension, often really contributing to that reflux pattern. If the stomach sits really high in the digestive tract, sometimes it's putting pressure up so that there is regurgitation happening into the esophagus. So we did that visceral manipulation treatment together to help with the reflux as well while she was doing the other work alongside. And 6 months later, her binging went from about once per day, maybe even sometimes more than once per day, to about once per month. Her hemoglobin A1C dropped from 5.8 down to 5.6. And just as an aside, there was no weight loss involved in this and no encouragement of weight loss through this entire process. Her LDL cholesterol went significantly dropped. It's now at 101, so almost nearly in that normal range. And her total cholesterol also dropped significantly down to 104. Her liver enzymes were all normal as well. And that was just in a six-month period of time. With the appropriate support, the appropriate systems in place, someone can make really significant change in a pretty quick amount of time. But really, it's really ensuring that all of those support systems are in place. And the person has to be ready to have that support there. Sometimes people start treatment and it's not the right time, or they're not in a place where they could commit to not actively trying to lose weight or restrict at that time. So this is a success story, and sometimes it may take a little bit longer. Every situation looks a little bit different. By the end of it, she had improved energy and her reflex was improving, and we're still working on the reflex component, still providing that visceral treatment periodically, but overall she's feeling significantly better. And she continues with therapy. She's no longer needing that dietitian support, maybe every now and then as a tune-up, but continuing to work with therapy to really start to continue to uncover all the ways that her body has maybe been harmed in culture around weight bias that was contributing to some of those behaviors, making sure that she's maintaining her recovery in that way. So a happy success story there. So I think I shared a lot of this already, but just what I love about naturopathic medicine is that the philosophy always applies. I'm at a place in practice where I can walk in and it may be a condition that I've never treated before or that I'm not as familiar with. But naturopathic philosophy gives us a foundation to understand the body well enough to be able to know how to take those first steps. Definitely even underneath that, it gives us the time and the space to be able to connect with the patient in a way that I think a lot of other medical providers don't have the time or capacity to do so. So it makes me feel like we have a broad spectrum of people that we can support, and we can be flexible in the types of treatments that we provide in that. And there are so many different treatment tools that we have that we can really use an individualized approach with each individual. For instance, I have a lot of patients that tell me they don't want to take supplements, or that they maybe have a hard time with capsules. And so that we get creative around, well, what therapeutics do they feel okay taking? I think there's also a lot of exploration when someone has really strong opinions on what feels good in their body. There's also information for me to learn about their body, why that might be true. So if someone doesn't like capsules, I use a lot of tinctures, so herbal extracts that are in a liquid form. If someone doesn't want to take a supplement, sometimes homeopathy is an excellent tool. Sometimes people need to come in and just feel the support of a medical provider that is hearing them, and they aren't ready to have any other forms of treatment. So we may stay in that space, which in itself is therapeutic and a treatment as well. So I love the diversity of tools that we have and the philosophy to be able to back up those treatment tools. So looking forward, I think I mentioned just that there is a big need for further eating disorder treatment training opportunities. So I have a CNME residency starting in this October. Applications come out shortly, which I'm really excited to be participating in. I'm providing continuing education classes in eating disorder treatment currently. There's a 4-course series that's happening. We just had the first course. The next one is happening on February 23rd. We do in-depth look at talking about weight bias, and I use an intuitive eating model for talking about nutrition. And then we do a lot of discussion around lab analysis and how to really support someone with an eating disorder or in that diagnosis of an eating disorder. And we need to promote decreased weight bias in healthcare as primary eating disorder prevention strategies. This is a piece, I think, going back to the idea that we all need to be doing our own work in this in order to be able to provide safe care. There's a lot of amazing resources and books and podcasts out there, and how as providers we can all be doing their own work. So if resources there are needed, please feel free to reach out. And then we need to promote all foundations of health, with diet and exercise being only a small part of the larger foundations at play. And I think that's a reason I chose naturopathic medicine. I think some people choose naturopathic medicine because of the strong contribution of nutrition and exercise. But really, it's a medicine that supports our social and emotional and spiritual foundations of health as well. And so I like to really emphasize that we need to support all of those equally and not just focusing on one foundation of health. And in that is actually eating disorder prevention work as well. And we need to create a naturopathic medicine board certification in eating disorder treatment. That's kind of my long-term career goal, to further the certification process, to really make sure that people are getting the appropriate training in eating disorder care. So I'm hopeful for that in the future as well. Here's some contact information. It has been a pleasure to share this information with you, and I think we have some question and answer time here.
Thank you so much, Dr. Stokely. I really appreciate it. If you can go on to the next slide, I'll just make a real quick housekeeping announcement. So our upcoming events that we have, we are hosting a virtual fair on March 24th, which is focused, you'll have all of the schools, including students and doctors and admissions folks, available to answer your questions about each one of the schools. And then kind of going along on this topic, we've got a webinar about food as medicine on March 26th. So we're really excited to bring all of this to you, and we look forward to hopefully seeing you at some of our upcoming events in the future. So with that, we have a few questions that have already come in. One was in working with other professionals, and so I think this is a nod to not all professionals are created equally. Not all NDs have a focus in eating disorder treatment. Not all nutritionists may be looking at this in the same lens that we might be. So how do you go about creating that network of professionals for yourself, including nutritionists and maybe massage therapists and other folks that are sensitive to some of the issues that are very particularly specific for folks with different types of body image stuff? And I know we didn't even touch on body dysmorphic disorder and all of the other things that kind of get thrown into this bucket, but how do you go about building that team?
Yeah, it's a great question. And at the beginning of kind of starting my practice, I spent a lot of time going to coffee with other providers, hopping on phone calls with other providers. Before I ever safely refer a patient to any provider, I always want to make sure I've had some kind of a contact with that provider. So I do place a lot of cold calls into providers if I'm considering referring to that individual. I will ask really specific questions of information around eating disorder care that I feel like if I will safely refer with someone that has an eating disorder, that I really want that provider to already know and understand. So I ask some questions. It's kind of probing a little bit to see, are they a safe referral for that individual? Do they have enough information to at least be preventing harm for that individual? And then also, are they willing to provide the appropriate treatments that I feel like are needed at that time for that individual to continue healing? So I have a lot of contact with providers. It takes up a lot of time. And I think I said also it's a big part of what I enjoy about this job is that I feel really connected with a lot of other medical providers. And it's also good practice. I think it's also great for naturopathic medicine to like get our name out there, talking to MDs, even talking to therapists and dietitians to know that there are naturopathic medicines that are really skilled in this realm that can provide support there. And I think also there's a huge need for referrals in eating disorder care. And so for someone to know that I provide that type of care, it's been a really big practice builder. So it's been a great way for people to know who to refer to me as well.
Thank you so much. There's a question here about atypical anorexia nervosa and maybe diseases that aren't fitting exactly the DSM. How do you work with those types of coding as well as criteria in patients that may not, and I think you talked about this a little bit with, patients that are at different body sizes and may have other presentations that aren't exactly the quote unquote DSM diagnosis.
Yeah. So in the DSM, there is an other specified eating disorder. And basically the way that's categorized is that they have maybe almost all of the criteria of one of the other eating disorders, but they just miss it by maybe like 1 or 2 marks. So for instance, atypical anorexia, they may have all of the symptoms of anorexia except for the low BMI component. And so really we're still using those DSM-5 criteria to be able to assess for what types of eating disorders that individual might be struggling with. I think another thing that I'm using is in those 2 questions I shared around what is your relationship with food and what is your relationship with your body. If I'm getting some big indicators that there's major stressors occurring in those 2 categories, then that is kind of pushing me into that I need to do more evaluation for that individual to really dig in around how, what is their food intake like? What is their exercise like? Are they menstruating if they're in a female body? What are other, do they have bone loss is another question, or something we might evaluate. So there's a lot of other markers that in atypical anorexia, even with that BMI standard not being present, where we can still see a lot of those body decompensation components present, that kind of guides in that diagnosis. And hopefully that answers the question there.
Thank you. I have a question here about any resources, like is there protocols or flowcharts or other areas when you were early on working on this that helped guide you to appropriate management?
Yeah, great question. I think I used a lot of different, so Jennifer Guadiani, the physician that I had the name written at the beginning of the presentation, she just released a book called Sick Enough. I think the name also speaks to what I was describing, of that a lot of the time patients don't feel sick enough to warrant care. Her book is fantastic. It's actually designed for medical providers, but also for patients to read. And she also has a lot of kind of patient stories intertwined. So I really recommend reading that book if you're wanting to explore eating disorder care more, or experiencing an eating disorder, or in recovery in your own body. And then Dr. Philip Mailer also has a book that's called Clinical Applications of Eating Disorders, and that is another really great resource. It's speaking to more of the kind of higher risk eating disorder components, and I think that's important to learn about first, and then kind of work back from, to understand the more mild effects that can show up with disordered eating disorders as well. There's a lot of online coursework that's happening around eating disorder care as well. And there's a couple organizations to look into if you're interested in this work. One is the Body Positive that I mentioned in the Bay Area. The other is Be Nourished in Portland, Oregon. They do incredible trainings around basically how to start really debunking and supporting people amidst a weight biased culture that's contributing to a lot of eating disorders. So those are two organizations that I really encourage getting involved in some form if wanting to do this work as well.
Thank you. We received a couple questions about fasting, and I know this becomes a little bit tricky when you're talking about with folks who have disordered eating practices, body image issues, and so on. And so, and I know there's a lot going on right now, a lot in the news, a lot in literature around intermittent fasting and questions around that. And so I'm wondering if you can talk about the role of fasting. And I know from a religious perspective, there are many cultures that incorporate fasting as part of their religious practices as well. And I love that you spoke of the cultural changes and the cultural impact, and how food is a part of our culture too, and how we were raised. So I'm wondering if you could speak a little bit regarding fasting, and that, knowing that fasting may be a part of someone's culture, it may be a part of the environment, and then there's all this stuff now going on about intermittent fasting and the potential benefits. And so what are your thoughts there?
Yeah, it's a great question. And I just want to start with actually the kind of spiritual practices around fasting, that those can be quite different than our current kind of health model of fasting. And so I just want to make sure that those are really distinguished as pretty separate. And I think one of the things that I differentiate in that and talk about when someone is asking about fasting, if that's something that they should be doing for health in their body, is that the fasting that is often associated with a spiritual practice, it's really intended most of the time as a time of rest, of a time of almost full body rest, of pulling away from other kind of interferences, to be able to rest the mind, to engage in a spiritual practice more deeply. And I think one of the issues I have with fasting when people are talking about it in regards to health is that people are applying it in a busy life, not pulling away from other activities, and in some ways causing a lot of stress in their body. And it's not necessarily applied as a time of rest. And fasting, it takes a lot of energy. It can be really hard on the body. I will say it is also a major, major risk factor for triggering an eating disorder. And so when we're talking about eating disorder prevention, I would never safely recommend fasting in my medical practice. What I say about any diet or diet trend, and I would call fasting a diet trend right now, is that there are some people and some people's bodies that probably feel really good in these different diet models. And that does not mean that everyone feels good on it. That also does not mean that it's healthy for everyone. And as a medical provider, and also in our pretty short-term research that we have on a lot of these therapeutics that are being talked about in the diet world, we don't have long-term research showing us these benefits. It's all very short-term research and very new ideas coming up around the potential benefits and also the potential harms in these therapeutics that are being recommended. And so what I say to other providers that I'm training with eating disorder prevention is that if you don't know how to accurately screen for an eating disorder, you cannot accurately prescribe these diets because you're going to put someone at risk. And so I think a lot of people are starting to talk about the health benefits of fasting in this way. What I say is if there is any risk that you're giving someone an eating disorder, it outweighs the possible benefits. I don't feel comfortable with that already. Eating disorders have the highest mortality rate of any mental health condition. It's often something that once someone develops an eating disorder that many people will struggle with for the rest of their lives in terms of the thought processes that may be present in their bodies. So I don't feel safe prescribing it. And I don't want to devalidate anyone that is attempting this or feeling good in that type of diet model. And what I say to that is I want you to keep listening to your body. If at any point your body is telling you that fasting doesn't feel good anymore, then listen to that. There may be also naturally times in all human bodies where our hunger cues are not as strong, where maybe we don't want to eat as much. And if we're using an intuitive eating model of really being able to listen to our body signals, we'd be able to listen to when our body doesn't want to eat as much. We'd also be able to listen to our body when it wants to eat more. And I think naturally our body, if we're following those cues, will go through times where it doesn't want as much. And then also times when it wants a lot more. So what I think the fasting is actually mimicking a body process that may already occur, but it may be occurring and being implemented in times when it's actually causing more stress to the body. And what I find in a lot of lab analysis is that it is causing stress. Cortisol levels often spike. I find lipid and cholesterol dysregulation a lot of the time when people are doing kind of different forms of these restrictive diets. So I think there's a lot of components that are being missed potentially because the analysis isn't being done appropriately.
Thank you for that. I really appreciate that response. So there's another question here about emotional release techniques and other types of biofeedback, because I kind of lump that in a little bit, almost like a biofeedback type of a thing. So can you speak to the role of that in helping, and I loved what you said about the intuitive eating and that awareness, the mindfulness regarding eating and food?
Yeah, there are so many incredible techniques out there that I think are incorporating body awareness as a tool to be able to really respect the body signals that our body gives us on a daily basis that I think a lot of the time we're programmed maybe not to listen to. And so biofeedback is an incredible example of that, of a tool that can be really helpful in eating disorder treatment. And I think also eating disorder prevention, of being aware of what our body is telling us so we can respond in a way that is deeply caring for the body there. I think emotional release technique and emotional freedom technique, there are so many different therapeutic models. And I think another part of the role that I'm playing as a naturopathic physician is also identifying kind of the ways in which someone might be needing support to be able to safely recommend the technique that I think might be of most benefit to them. For instance, those that are struggling with anorexia, a lot of the time, most of the time, this is a generalization, there is a sense of need for over control. So there are therapeutic models that are about really releasing that control. So there's DBT is a component of that. There's also RODBT is another one. So there's sometimes are specific eating disorders where I will make referrals to specific providers doing specific techniques that I think will really enhance their treatment over time. So all of those different modalities are totally valid in eating disorder care. And I think as a naturopathic physician, we can practice a lot of those. It's not necessarily in our best interest to try to become experts in everything, but to be able to have a general understanding of a lot of these different tools, maybe have a few tools that we really hone in on, and then knowing when to appropriately send out to use these other tools, I think is a really great asset to be able to provide as a naturopathic physician. Oops, I can't hear you, Joanne. I think you're on mute there.
Thank you. There are a couple other questions, but there's one thing that I wanted to touch on this webinar, which is some of the language that we use around food. And you started to talk about that a little bit, how maybe we have this unconscious bias around how we discuss food. And one of the things that I have personally seen and have been guilty of saying myself are things like eating clean, or that's junk food, and labeling types of foods and behaviors and certain things around that. And so I'm wondering if you can speak a little bit about the languaging that you use in your clinic and how you message things around food to create more of a less threatening environment around food and body image and messaging and so on.
Yeah, thanks for bringing that question up. And I think, well, first of all, I just want to acknowledge that we're all part of this culture around diet and food, and we are all at fault for participating in it, even with many, almost 2 decades of experience in developing this language. I still will say things that I'm like, ooh, that was not a great thing to be contributing to in that way. So I just want to welcome everyone, that we're all learning in this. And I think as a provider, it's also our role to prevent harm. And so if we're seeing this show up in other people, other providers, it's an opportunity for learning for all of us. And it's humbling. We all need to be continuing to do our own work in it. I think a big piece of it in this work with eating disorder prevention is that we need to remember that all food is food. And part of this work is really, and this is hard for people to hear, to debunk the idea of good and bad food, that all food is food. And if we start classifying food as good and bad food, we're actually putting ourselves in a place where we're moralizing food in some ways, which is a pretty privileged stance to be sitting in. It actually disregards a lot of people's limited access to food. So there will be an inherent shame associated with not having access to the foods we might be classifying as good or bad. And I think there's a lot of problems immersed in that. And I think that in itself also starts to affect health and access to healthcare and components there. So I could talk for a long time around those pieces of it. But I think the foundation is really starting to identify the ways that we're classifying good and bad foods, or healthy and not healthy foods, or even healthy and not healthy behaviors. And this is looking at that we are all making decisions around our food and health decisions that are to the best of our ability. So for instance, I say, if you're choosing that wine and chocolate at night, there's probably an emotional reason that you're doing that. And I don't want to tell you that that emotional reason is bad. Now, if you do that every night, it might not start to feel good in your body. And that's what I want to connect you with, of like, that I want you to feel your best. And so this isn't saying just go eat whatever you want. This is saying, I want you to tune into your body signals to guide you in what is healthy and not healthy, rather than me telling you what is healthy and not healthy, because everyone's going to have a slightly different approach to that. And the other way I frame that is, if we followed all of the diet advice that's been given in the last 2 decades, we would all be eating nothing. And so we can't continue to listen to the fad diets that are coming up. We have to use our bodies as the main tool to guide us in that. So I see myself as kind of the facilitator in helping someone start to listen to those messages.
Thank you. Yeah, that it is such an important role. And I think that we all come to the table with some sort of a privilege. And, just the fact of being able to make a choice to restrict your food is privilege. And so I think that is a very important comment. I loved that you touched upon culture and differences and privilege, and because it's all part of the conversation. There are a couple of questions here regarding weight gain for anorexia and health of every size training, different types of resources. I'm wondering if before we close out here, if we can just talk about, and I know that the healthy weight gain for anorexia is very tricky, and it's going to depend on the patient. Some people may need to be hospitalized to, if they've got organ failure starting, or, different types of things going on internally. But if you can maybe just touch on the health at every size piece, that would be great.
Yeah. So health at every size. For those of you that are new to that model, it's the idea that we don't need to be promoting weight loss to be promoting health. And that it's the idea that a body, if we are promoting healthy behaviors, that a body will come to its size in the way that it best needs to. And sometimes that is of a size that is beyond our BMI standards. And I also don't use BMI as a marker in my practice. I also don't use obesity as a diagnosis in my practice, partly for these reasons, that it's pathologizing a body size that actually may not have a pathology. So health at every size trainings, the Be Nourished group in Oregon is a wonderful place to get health at every size training. There is a book by Linda Bacon called Health at Every Size. I call it kind of the Bible of this knowledge. It's a very long read. It has a ton of interesting research in it. And those are kind of the two starting places that I generally recommend. There's also a website called ASDA. It's the Association of Size, Diversity, and Health, ASDAH. And they have a lot of resources on their website. It's also a donation-based membership that you can join to receive their newsletter. There's also provider lists of providers that are practicing in this way. So a lot of resources, a lot of research out there representing a Health at Every Size model. And I think there was one other part of that question, and I don't recall which part that was, if you can remind me, Joanne.
Oh, it was just around, and I answered it on the side a little bit as well, but just regarding if with anorexic patients and reestablishing weight. And I think that you touched on that earlier, that it's more about renourishment than just putting on weight, and also it will be very dependent upon the health of their organs and if they have to be hospitalized and all of that.
Totally. Yeah, I think I have a hard time telling someone what their target weight should be. Part of that is in the model of Health at Every Size. I don't think as physicians, we actually have the ability to estimate what someone's weight should healthily be. So what I tell people is that I can't guarantee where your weight should be. When I'm dealing with someone that's struggling with anorexia, a lot of the time what I tell them is I can give them an estimate that I think their body may need to get to this point to be able to have a return of full body functions. But beyond that, we have to continue to work in their recovery and work around body image to be able to find the place that's their target weight. And some ways I define that is return of body functions, improvement in mood. A big one is just that a decrease in thinking about food all the time is a sign that someone is nourished. So it's a check-in for ourselves. If we find we are thinking about food all of the time, it may mean that we are not eating enough. And so the basic things like that, there's a lot of other ones that can kind of go into that, of markers that would tell someone that they're becoming nourished. Yeah.
So that concludes our webinar. I am so thankful that you spent some time with us today and shared the experience and the knowledge that you have gathered over the years. We put up your contact information earlier. Maybe if you can just throw that slide real quickly back up. For folks wanting to connect with you. And with that, we conclude our webinar. I hope that you'll join us again in the future. And thank you so very much, Dr. Stokely, for this really informative webinar on eating disorders and disordered eating and body image. Thanks very much all, and hope that you'll join us again in the future.